Good morning and good afternoon and good evening, everyone, depending upon from where you're joining us. And welcome to the very first co-hosted webinar between IPOSC and an orthoptic member society. I'm Shelley Klein from Tufts Medical Center in Boston, Massachusetts, and the AACO representative to IPOSC. As orthoptists and pediatric ophthalmologists, our shared goal is to perform the most thorough preoperative orthoptic exam to ensure a successful surgical outcome. We do not like surprises. We like happy patients, and we like happy parents. With that in mind, we put together an expert group of panelists of pediatric ophthalmologists and orthoptists who will address some of those crucial components to that orthoptic pre-op exam. But before starting our webinar, as a co-host, I'm given the opportunity to tell you a little bit about the AACO. Dan, if you could switch that slide. Thanks. The American Association of Certified Orthoptists was established in 1940. We're a professional organization, the only one in the United States for orthoptists. We have about 275 active members. There are 4 regions, the East, South, Midwest, and West, which represents all the states of the United States. And we're comprised of an executive committee, board of directors, and many standing committees. Our mission is to provide continuing education to its members, to assist members in their professional practice, to improve the care of children and adults with disorders of binocular vision and ocular motility, and to promote orthoptics as a profession. Our certifying body in the United States is the American Orthoptic Council, and they're the ones who manage our boards, our orals and written exam, and our recertification. Our official journal of the AACO was formerly called the American Orthoptic Journal, but is now called the Journal of Binocular Vision and Ocular Motility, is a member's benefit. And I'm proud to say that Kyle Arnoldi, one of our panelists, is one of the co-editors. In order to provide our continuing education credits, we hold an annual meeting. This year, our meeting is going to be held in San Francisco, and it is from November 4th through 6th. You're all invited to register if you're interested. I know that can be challenging, but the meeting will actually be recorded if you're interested in viewing it afterwards. And for more information, please visit us at www.orthoptics.org. And now I'd like to introduce to you my co-moderator, Dr. Stephen Christiansen, the chairman of the Department of Ophthalmology and professor of ophthalmology and pediatrics at Boston University School of Medicine here in Boston, Massachusetts. Steve?
Thanks very much, Shelley. And I want to say thank you publicly to you for all the hard work that you've put into this webinar. I think if we're successful at all, it'll be a tribute to you and to the work that you've done. So thank you very much for your partnership in this and for inviting me to participate in this.
Thank
It's
you.
my pleasure as a pediatric ophthalmologist to also represent IPOSC, the International Pediatric Ophthalmology and Strabismus Council, and in particular, the subcommittee that I've had the privilege of sharing responsibility for with Cindy Pritchard over the last couple of years. IPET is a committee, as I mentioned, of IPOSC, and our purpose is to train eye care providers, non-MD eye care providers, I should add, in sub-Saharan Africa. Many of you are aware that there are few pediatric ophthalmologists in Africa, period, and in many countries there are no pediatric ophthalmologists whatsoever. And a very telling conversation that we had last year with an ophthalmologist and with one of the government officials at the Ministry of Health was that people basically assumed that children didn't need eye care, that basically people didn't really need eye care until they were about age 35. So many children with potentially vision-threatening eye conditions were completely ignored, and there was no screening that happened whatsoever. And screening is an excellent process for examining children who have potentially vision-threatening issues, but unless there's a provider that can see these children and get them started in the in the healthcare system, then there's not going to be any advantage to them for screening. So these eye care providers now are going to be able to examine children. They'll be able to treat basic eye conditions and refractive error. They'll be able to start patching in the case of amblyopia. And if there's structural or other issues that require surgical intervention, they can refer them up the chain to the ophthalmologist. We're excited to be able to report that our first class has already successfully graduated, and the first class are now in their internship and are training the next generation, the next class of pediatric eye care providers in the Gambia. We are partnering with Sheikh Zayed Regional Eye Care Center and the Ministry of Health in the Gambia. They already have established training programs for ophthalmic nurses and ophthalmic nurse cataract surgeons, which is kind of an interesting combination and very unique to Africa. And so we're happy to be able to partner with them to provide orthoptic training and pediatric eye care training in the Gambia. Well, without any further ado, I think we should get started. We're excited to present to you this webinar on the preoperative orthoptic evaluation of patients. And our first speaker will be Mary DeYoung-Smith. She's at Kresge Eye Institute and Children's Eye Care of Michigan in Detroit. And Mary's title is, as you see, Measure Twice, Cut Once. Thank you very much, Mary, for presenting, and we look forward to your presentation.
Thank you, Dr. Christiansen. Thank you to IPOSC and the AACO for this webinar, and also for the opportunity to participate. Special thanks to Shelley Klein and Dr. Christiansen for the invitation. I will discuss getting those critical numbers for surgical planning, what measurements are necessary, and how to achieve the accuracy needed. The first step is a good evaluation of the extraocular movements, and your prism measurements should make sense with what you see. You're probably aware of how to hold the type of prism that you use, and this is critical for prisms 20 diopters or larger. For near measurements, you should be rotating the prism slightly nasally, and in future slides, I will be talking about plastic prism placement. Some patients don't like you to hold the prism too close to them, but you do need to be as close as possible, especially for near fixation. The power of the prism is reduced as the prism is held further from the eye and closer to the target. There we go. Although it is best not to hold two prisms in the same direction, you can hold a horizontal and vertical prism together. Holding the prism for lateral gaze measurements requires you to be aware of how to hold it correctly. The back surface of the prism needs to be perpendicular to the line of sight. So be careful not to over-rotate the prism with the frontal plane of the patient's head. Large angles over 50 prism diopters will require you to split the prisms between the two eyes. If your patient is capable of holding one of the prisms, you can have them hold one, but be sure that this prism is held in the proper position. This table from Thompson and Guyton tells us what the two split prisms are actually measuring, and it isn't additive. As you can see, if you hold a 50 diopter prism over one eye and a 45 over the other to neutralize an angle, that is actually 123 prism diopters. Paretic or restricted conditions require you to hold the prism over the eye with the paresis or restriction in order to measure the primary deviation. That is, with the non-affected eye fixating. This would be for nerve palsies, Duane syndrome, Brown syndrome, thyroid eye disease, and others. So what do we need to do? Always primary and secondary positions. Tertiary positions, those measurements in the corners, need to be measured when you have concomitant vertical deviation, and those patients who have had previously operated on vertically acting muscles. Measure 30 degrees from primary position, which is about half of a full duction. Head tilt measurements and cyclodeviations should be measured, again, when there are concomitant vertical deviations, and especially when a patient exhibits a head tilt. Our secondary measurements are needed to measure pattern strabismus. Right and left gazes are very helpful when we're measuring DVDs and inferior oblique or superior oblique over and under actions. And as I mentioned, tertiary measurements, those measurements in the corners, are done in particular situations, as I stated on the last slide and is stated here. XTs and intermittent XTs need a far distance measurement, preferably on an outdoor target. They also need prolonged monocular occlusion to find the largest angle and help to determine what type of exodeviation they have. We have patients wear a patch before they come into the office, and make sure that you cover the other eye when you take the patch off, and do not let the patient regain fusion until you have completed your measurements. Also, exodeviations need prolonged monocular occlusion before measuring their ACA ratio. So what do we need to do? Keep good dissociation throughout your measurements. You need good accommodative targets for accurate measurements. Be aware of the best vision of your patient's worst seeing eye. When you are doing alternate cover, the patient needs to be able to see the target with each eye. And keep in mind, if you're using larger prisms, you may need a little larger target just so the patient can see it. You don't want the patient staring at a target, getting bored. Your measurements are not going to be as good. You need to keep them engaged. And neutralize vertical deviations along with your horizontal deviation to have the best accuracy. When you are measuring in right and left gazes, especially for angles 20 diopters or more, it is best to measure with the prism over the adducting eye with exotropia, and measure with the prism over the abducting eye for esotropia. Significant angle kappas affect a patient's appearance. As you know, a child with a large positive angle kappa and an esotropia may have good cosmesis. If the patient won't have improved binocularity from surgery, you may not want to operate. Refractive errors over 5 diopters will affect your measurements. And we just remember that minus measures more, which also means that when your patient's looking through hyperopic lenses, your measurement will actually be less than their true deviation. The percentage of change in the prism measurements by the spectacles is determined by the strength of the lenses. If you have a patient who can wear contact lenses for their pre-op measurements, then you are no longer concerned about prismatic effect, and that really works out well. However, this table shows us how the spectacle lenses changes our measurements. Patient 1 measures an XT of 20 looking through minus 10 lenses, and you can see that XT, the true angle is actually less. Patient 3 measures an RHT of 35 looking through plus 10 lenses, but the RHT is actually much larger. When you're measuring a DVD, you need to measure each eye separately. So you occlude one eye, you're going to hold the prism behind the occluder, and then after a prolonged dissociation there, you watch the eye, and if it's still coming down, you're going to add more base down prism. This patient also has an XT. And once you complete and neutralize the angle over this eye, it's the left eye, then we repeat this for the right eye. Also, as you know, patients with DVD frequently have inferior oblique overaction, and your secondary measurements must be performed. With significant nystagmus, your measurements may not be completely accurate. It is hard to find the endpoint when performing Prism alternate cover measurements. So watch your patient, look at the amplitude and direction of the nystagmus before measuring, then do your Prism evaluation, keeping in mind your observation of the nystagmus. You can and should use a Spielman or frosted occluder for those patients with latent nystagmus, but you may need to do Krimsky measurements with a larger amplitude nystagmus. Pay attention to null points and head postures, make note of them, and take careful measurements of them. A patient with poor visual acuity, 2200 or less in one or both eyes, really should have Krimsky measurements performed. These patients cannot fixate well for Prism alternate cover, and it's best for you to hold the Prism over the fixing eye in these cases to better observe the light reflex in the deviating eye. We all have patients who come to us anxious and upset. You can set the tone in the room, keep it calm. Some things that are helpful, if there are other people in the room, other family members, if you can keep them seated and out of the line of sight. For young children, have lots of different fixation targets. Videos on the parents' phones are very, very useful. And for your very anxious patients, make sure you tell them everything you are doing, including moving the chair up or down. Don't surprise them. And you may find that you have to use Hirschberg measurements with some of your very upset patients. They may not allow a Prism in front of their eyes. So if you're doing that, don't forget to do secondary measurements. For your upset, uncooperative patient, be as efficient as possible. Do your most important measurements first. Also, if these are young children, have them sit with their parent. If they have a favorite toy, they can hold that. If they need a break for a snack, do that as well. And know that sometimes the measurements may have to take place over 2 visits. So in summary, be aware of possible Prism errors, measure in tertiary positions for certain patients, use Krimsky measurements with poor vision, and keep a calm environment for those upset patients. Thank you.
Mary, that was terrific, and I really appreciate the thoroughness of your presentation today. For those of you who had questions, and I see we have one already, please be aware that we're going to have our question and answer session at the very end of the webinar. So hold on to those questions, but please enter them in the Q&A box at the bottom of your screen. Be aware that although the chat is available, we're not going to be monitoring that. So if you have questions, make sure they go in the Q&A. Shelley is going to present now our next speaker.
Okay, Mary, that was wonderful. Thank you so much. Our next speaker is Kyle Arnoldi, Chief Orthoptist at the Ross Eye Institute in Buffalo, New York. And her talk is going to be on forgotten components of the sensory measurement. I'm sorry, of the sensory exam. Sorry, Kyle. Thank you.
No problem, Shelley. Thank you, Shelley. Thank you, Steve. And a big thanks to IPOSC and the AACO for sponsoring this webinar. So as the title of my talk implies, I'm going to be talking about not the tip of the iceberg, but what's underneath the surface, what you might be missing in a preoperative sensory exam that could actually really help you. I have no financial relationships or conflicts of interest to disclose. Of the 3 types of binocular vision for which we have a clinical test and can actually evaluate in the clinic without taking the patient to a vision lab, stereopsis by far and away gets the best press. Stereopsis is the most visible of the types. It certainly says a lot about the success of your surgical procedure if your patient develops it postoperatively. But it's not really that helpful to test stereopsis at the pre-op exam. unless, of course, you've been using that as a measure to determine deterioration of an intermittent deviation. Sensory fusion, we typically do test in the pre-op exam, but our goal really usually is to determine whether or not the patient will have fusion, or at least the absence of diplopia. But sensory fusion testing also gives us valuable information about suppression and correspondence. And it's possible that the size and depth of the suppression scotoma may actually impact your outcome. And then there's motor fusion. In my opinion, the most overlooked and underrated type of binocular vision. It is fusional vergence, after all, that keeps the eyes aligned. Testing motor fusion preoperatively can help you to identify a margin of error for your surgery and also may predict response to postoperative drift. Okay, this little icon shouldn't be here. Not yet, anyway. Now, I want to talk about suppression and fusional vergence today. Those two are actually interrelated in a very important way. When you have an eye misalignment, the alignment error projects similar images onto non-corresponding points. This is detected by the visual cortex, and that is what is going to trigger your vergence signal. And then vergence turns on and, if possible, restores eye alignment. If you have suppression, which is what our skull and crossbones is intended to represent here, this disrupts the entire process, and your patient will have a manifest deviation that actually may work to deepen the suppression, and it's sort of a vicious circle that keeps making things worse. Now, I want to be clear here, I'm not talking about foveal suppression. A very deep foveal suppression scotoma can absolutely coexist with fusional vergence. We see this all the time in monofixation syndrome. What I'm talking about is a suppression scotoma that extends into the retinal periphery, because peripheral stimuli are a much stronger stimulus for vergence. So it can be useful for us to either estimate or measure the size and location of the suppression scotoma, as well as the depth or severity of the scotoma. We can predict the boundaries of the scotoma based on the patient's history of the size of the deviation, or we can measure it using a synoptophore or prisms. When it comes to the depth of the scotoma, this is usually positively correlated with the duration of the misalignment. So the longer the misalignment has been present, the deeper the suppression probably is. This can also be quantified using a red filter bar or with the collection of sensory fusion tests that are presented under multiple levels of dissociating conditions. Now, before I continue, I want to explain what I mean by fusion-friendly environment, because I'm going to be using that term. As you know, suppression is present under binocular conditions, all binocular conditions. So it may still be there during the latent phase of an intermittent deviation, and it may still be there after you have surgically realigned the eyes. This is why it's a danger. Any visual environment that is conducive to sensory fusion is also conducive to suppression. What do I mean by fusion-friendly? Comfortable room illumination, contours in the peripheral field whose images will fall within the binocular field, and testing with minimal dissociation. Let's first talk about mapping the boundaries of suppression, what I call the low-tech way. We offset the deviation with an appropriate prism. I usually use a prism bar here, but you can do this on the synoptophore in a fusion-friendly environment and verify the absence of diplopia. Then you gradually decrease the prism power until diplopia is reported. Now, this sounds simple, but it can be very tricky. You have to observe the patient's eyes through the prism to make sure that the deviation is still manifest. Just because your patient has a manifest strabismus does not mean they have no fusional vergences. So in some cases, this method is going to be problematic. The way I prefer is to use the synoptophore. I set the arms of the synoptophore at the subjective angle, the angle where the brain wants the eyes to be in order to achieve fusion. From there, I'm going to use grade 2 slides for this purpose. These are the fusion slides. These slides have similar images, but there will be a fusion check on each slide that is different. So the right and left eyes will be seeing a slightly different image. Starting with the largest image, I present each set, decreasing in size until the fusion check for the non-dominant eye disappears. At this point, I may slowly move the arm of the synoptophore over a small range to straddle the subjective angle and determine just how big that scotoma is. These are the type of slides that I use for this purpose. If you have a very small foveal scotoma, you may be able to see all of the slides until we get to this last one here, where we have a very tiny little crescent moon and a tiny little flag. So only those who have bifoveal fusion are going to be able to see those two fusion checks. This is the medium-sized fusion check, and this would be the large. Patients who have a very large suppression scotoma will even suppress on grade 1 targets where the images are big and dissimilar. Now, mapping the depth of the suppression scotoma, the high-tech way, this is my preferred method these days, ever since I got a red filter bar. Under fusion-friendly conditions, I put the lightest, palest, pinkish filter right at the top here over the dominant eye. Now, I should tell you that this is my method. Not everyone uses the red filter bar in this way. I will slowly move down the bar, increasing the density of the filter, reducing the luminance that the dominant eye is being presented with until one of the following occurs. The patient reports diplopia with one red image and one normal. The patient switches fixation, or in the case of an intermittent deviation, the deviation becomes manifest. But before I had a red filter bar, I used what I call the low-tech way. I would assemble various sensory fusion tests, as you see here, and present them in sequence, going from a minimally dissociating test, such as the Bagolini glasses, in a well-lit room, and then gradually making the environment less fusion-friendly by turning the lights off, going to a more dissociating test, until finally I end up with the negative after image. Patients who suppress under that circumstance have a very deep-seated suppression. Now we move on to fusional vergences. So as I said before, I believe motor fusion is the most important type of binocular vision, the one that the patients will benefit the most from. When we measure preoperative vergence amplitudes, we can do this to reveal the target range and the margin of error for surgery. We're going to hear sometime this morning about identifying the target angle for surgery, but it's nice to have that little range of comfort where you know if the patient ends up in this range, they will be comfortable post-operatively. We can also use this to estimate the ability of the patient to overcome a modest post-operative drift. And I use this as an objective, quantifiable measure of control over an intermittent deviation. Now, I prefer to use the Prism bar. Again, there are many options for this. Many people use the synoptophore instead. Some might use a rotary type of prism. I like the Prism bar because I can easily see the patient's eyes through the bar. This is important for me because the sign of fusion break that I use is the full deviation becoming manifest. For smaller angles, this can be difficult to see, so I might go in with a quick cover-uncover to make sure that both eyes are still fixing on the target. But I prefer this objective breakpoint to asking the patient to report to me whether or not they see double. In this way, because I'm using the objective breakpoint, I can do this on a child who may not understand the question if I'm asking them if they see double. But remember that our patients might not be reporting diplopia because they have suppression. It's also possible, I've had some patients mistake the prism-induced blur for diplopia or the monocular diplopia that they're getting from the Prism optics. And they interpret that as the fusion break. So when they report that to me, I still ask for it. They report it to me and I look to see whether or not their deviation is manifest. So to use this to quantify your target range, very simple. You're going to offset the deviation with Prism first, and then you will gradually reduce the Prism amount, undercorrecting it until fusion break. And then you go in the opposite direction and overcorrect the strabismus until fusion break. This is going to estimate the minimum amount of deviation that must be corrected in order to achieve fusion, and also estimates the response to an intentional small surgical overcorrection. I also use this method to quantify control over intermittent deviations to assist in determining the timing of surgery. So in this case, I'm going to orient the Prism bar to increase the vergence demand. So I'm going to use base in Prism for an IPOSC or base out for an EXO. Again, these are intermittent deviations, so I'm starting from their phoric posture. The adequate break point for control should equal about twice the baseline deviation. And it's also important to take the other step where you reduce the power of the Prism until fusion is restored. This is the recovery point, and a remote recovery point compared to the break point also suggests insufficient control over the intermittent deviation. So to summarize, the larger and or deeper the suppression scotoma, the greater the risk of decompensation over time, because suppression may be blocking the vergence system. And motor fusion test results may predict both early and late post-op sensory and motor results. The evaluation of sensory status is every bit as important as accurate measurements of the strabismus. Binocular vision can affect your surgical results. The assessment of fusion potential should include investigation of suppression and quantification of fusional vergences, in addition to determining fusion potential. The results may be useful in refining your surgical plan and predicting short and long-term response to surgery. And the results may help patients and their parents develop realistic expectations for outcome. Thank you.
Kyle, that was terrific. And as always, very, very thorough and insightful. Thank you so much for that presentation. It's my privilege now to introduce our next speaker, Dr. Mohamad Jaafar, a friend of mine, and also a generous supporter of IPET, which I was talking to you about earlier. He's the Chief Emeritus of Ophthalmology at Children's National in Washington, D.C., and his presentation is entitled Preoperative Evaluation of Torsion. Mohamad, thank you for speaking and looking forward to your talk.
Thank you very much, Steve. Thank you, Shelley, for organizing this seminar. I'm privileged to chair the board, the advisory board of IPOSC. So let me make some comments, and while doing this, I'm going to project what Dr. Yam has kindly put in the chat. This is how you can access the recording afterwards. So welcome to the more than 500 attendees from all over the world. And thank you to the American Association for Certified Orthoptists for co-chairing this webinar with IPOSC. It's a great program, and I also should thank the Education Committee of IPOSC, chaired by Dr. Jason Yam, and with the great help of Dr. Sonal Farzavandi and Dr. Sati Agabulia. It is unbelievable how much this committee has done, webinars, especially during the COVID season. So thank you again. And last but not least, let me give a big shout out to the IPET committee, co-chaired by Dr. Steve Christiansen and Cindy Pritchard, who has done a marvelous job in starting the IPOD program and moving it to the second level. As Steve has said, the first class has graduated, And we are looking forward to the second class and way beyond. It is a very worthwhile program. If you feel like supporting orthoptists and pediatric ophthalmology in Africa and all over the world, please donate to IPOSC to support IPED specifically. Without further ado, I'm going to talk about diplopia measurement. I have no financial interest to disclose. As we all know, diplopia in superior oblique palsy can present with a vertical deviation, a horizontal deviation, or a cyclotorsion. This is not unusual to have a patient presenting with an oblique diplopia, vertical and horizontal, and also complaining about the fact that one image is tilted, and sometimes both images are tilted. This is how they see a painting in their house. One of them is tilted. Kyle, thank you for your talk. You introduced the sign-up for that. Unfortunately, not very many of us in many centers all over the world have access to anymore. If we had a sign-up for it, would be very easy to put the patient on the machine and dial in the vertical and horizontal deviation and see if they can fuse. And if not, that we can dial in some cyclo measurements in there and ultimately see if they can fuse with that. We know that some patients who have a very long duration of the deviation are not able to fuse anymore. And we also know that patients who have very severe head trauma may lose their fusion potential. So it's really important to determine preoperatively if the patient is going to fuse, and also what is making their fusion impossible. Is it the vertical, the horizontal, or the cyclotorsion? This is a briefing of a gentleman we saw recently. He's 68-year-old with diplopia, mostly in down gaze, while reading and going down the stairs. He's truly tired of the chin down head posture. He sustained a traumatic brain injury 2 years ago. Luckily, he still has 60 seconds of arc of stereopsis with his anomalous head posture. Typical findings of bilateral superior oblique palsy, a small intermittent esotropia and hypertropia in prior position. The esotropia and hypertropia become constant in down gaze. He has an exotropia in up gaze, giving us a V pattern, a left hypertropia in right gaze, and a right hypertropia in left gaze. Wilczewski head tilt test was positive to both sides, and 8 prism diopters of right hypertropia with a right tilt, and 4 prism diopters of left hypertropia in left tilt. And we can also see the rotations. The patient has overaction of his inferior obliques and some underaction of the superior obliques. By fundoscopy, we could determine if the patient does or does not have cyclotorsion. This is a view taken with the direct ophthalmoscope or a fundus camera. We all know that the fovea is usually in between those two lines, horizontal lines, one from the center of the optic nerve and the other one from the inferior pole of the optic nerve. So the fovea should be somewhere in here, and this patient has left X cyclotorsion. This is the view with the direct ophthalmoscope, and the ophthalmologists usually use an indirect ophthalmoscope, and we can see the same phenomenon, but everything is reversed. This is an X cyclotorsion of the left eye. So let me go back to the measurement, orthoptics measurements that we do and have to do. We use the double Maddox rod, and this gentleman had in primary position 9 degrees of right X cyclotorsion and 4 degrees of left X cyclotorsion. That increases in down gaze, which again is important to measure, to 12 right X cyclo and 4 left X cyclo. By fundus examination, objectively, we could see that the patient has significant X cyclotorsion, +3 on the right eye and +2 in the left eye. So this gentleman in here has a small vertical and horizontal deviation, but a lot of cyclotorsion, and we need to address that as orthoptists and as pediatric ophthalmologists. This is taken from Van Noorden's Atlas of Strabismus that you may still find a copy somewhere in your library. And Van Noorden reminds us that some patients cannot see the two lines, the red and white. So introducing a prism, a vertical prism in front of one of the eyes, separates those two images, and then we ask the patient to dial the cylinder dial on the trial frame to make them parallel to each other and to the floor, and then we can read from the frame if the patient has X cyclotorsion in one eye or both eyes and how much it is. This is what the patient starts seeing, and neutralizing with prisms, the patient sees a vertical line with the right eye where the red filter is, and X cyclotorsion of the left eye. Very important to measure again in primary and down gaze. The Lancaster test is used by many of us. Dr. Guyton has talked about it forever, and it has the advantage of measuring both vertical and horizontal deviation along with cyclotorsion. As we can see in here, the patient does have a secondary left inferior oblique overaction, where most of the deviation is in the field of action of that inferior oblique. The patient also has vertical deviation and X cyclotorsion, especially in the field of action of the left superior oblique. Patient luckily is well aligned in primary position, and we want to make sure that whatever procedure we do surgically, we don't interfere with that alignment in primary position. We know that red goes over right and left green go over the left. The room lighting should be adjustable to dim the light as much as possible to enhance the dissociation and minimize diffusion. So we really want to get the maximum deviation in these tests in here. And in the words of Dr. Guyton, he says that Dr. Lancaster introduced his red-green test in 1939. He felt that any good test of heterophoria should assess the fixation of each eye simultaneously without the corrupting influence of a fusion stimulus. His basic concept was to utilize the strength of the cover test, namely accuracy in measuring the ocular deviation in the 9 diagnostic positions of gaze, while at the same time devising a way to measure quickly and accurately the position of the covered eye when the other eye is fixating. Let me emphasize in here that this is another dissociating test by design. Testing for cyclotorsion with the less dissociating Bagolini lenses may help us determine the patient's ability to cyclofuse once the vertical and or horizontal deviation are corrected with prism or surgery. As we can see on the left, the Bagolini lenses striations are set vertically at 90 degrees, and the patient is presented with a light, and as we know, the patient is going to see one white line in each eye, and then you can ask them if they are parallel to each other and to the floor. On the right, we see how we neutralize the vertical and horizontal deviation using prisms and see what the patient perceives. Again, here we are dissociating the patient the least and to see what we can get. We start with one where we have an oblique diplopia with cyclotorsion. By neutralizing with prisms in front of the Bagolini, the patient may get to 2, which is great. Knowing now that correcting the vertical and horizontal deviation, the patient's own cyclofusion potentials are going to make it 1. Unfortunately, in 3, in spite of aligning the vertical and horizontal deviation, the patient still see a second image that is torted on top of the first one. So what's the benefit of the Bagolini? Again, it is the least dissociating of the test, as Kyle mentioned to us. Here we are asking the patient behind those lenses to use the environment, the experience that they have in real life. Use the walls in the exam room, any paintings that we have, the chair, the fixation target at the end of the room, to make their best, to do their best and fuse if they can once the horizontal and vertical deviation are corrected with prism. This is a patient where I don't have to worry much about their cyclotorsion postoperatively, compared to this other patient who unfortunately does not have good cyclofusion, and in spite of correcting the vertical and horizontal, the lines are crisscrossing in the middle, the patient still is not able to cyclofuse. And this is a completely different surgical approach than the first one. So please get those Bagolini lenses out of your drawers, dust them off, and use them. It is this is how the patient is functioning in life. Get them to the best of their ability, and that will help them postoperatively. I thank you for your attention, and thank you, Steve and Shelley, for the invitation.
That was wonderful. That was just great. I'll have to dust off my Bagolini lenses. You're right. Our next speaker is Marla Shainberg, who is a certified orthoptist, currently working at iScreen Vision, and she is from Memphis, Tennessee, and she'll be speaking to us about Prism adaptation testing. Thank you. While Marla is pulling that up, I just want to remind people to put questions in the Q&A box. We will try to answer them during some of the talks, but if we don't get to those questions, we actually will have our panelists answer those questions afterwards, and the Q&A will be available on the YouTube IPOSC channel too. So definitely put your questions in, and we'll try to do the best we can. You're on, Marla. Thank you.
Thank you, Shelley and Steve, for your kind invitation to speak today. I appreciate IPOSC and AACO, as well as our host, the AAO, and I'm very grateful to be speaking to this audience today. I have no financial disclosures. The Prism Adaptation Test, or PAT, is a testing technique that was first described in the 1960s by Bagolini and other European clinicians. And in 1971, Jampolsky popularized PAT as a solution for surgically correcting a larger angle that may be otherwise masked. The Fresnel prism principle was developed in France by Augustin Fresnel about 150 years before Fresnel press-on prisms were first used to manage strabismus. A series of Fresnel press-on prisms was designed in California in 1970. It's a transparent plastic membrane that's less than 1 millimeter thick with multiple tiny prisms or angular grooves. It's cut to fit a spectacle lens and is then adhered with water to the inside surface of the lens. Back to the history. Scott concluded from a late 70s study that PAT is, quote, quite helpful in determining the amount of deviation to operate on and is a good prognosticator, end quote. Dr. Scott was the director of the first large-scale PAT trial in 1990. PAT is widely used in the preoperative period to determine the maximum angle of deviation that can be corrected with best binocular fusional outcome. How long is the test and for whom? Well, that varies from surgeon to surgeon, country to country. It lasts anywhere from 30 minutes to about 3.5 weeks and is performed on people of all ages between around age 3 years through adulthood. Motor stability and sensory fusion are the main goals for surgical success. Exclusion criteria in PAT, mostly neurologic and congenital strabismus, and those who have had previous strabismus surgery. Prisms are used to offset the initial angle of deviation, and the power is increased as the angle builds until fusion is either achieved or determined unattainable. Usually equal prism power is placed on each lens to minimize visual disparity and to maximize the chance for sensory fusion. The older age at ET onset increased the probability of a prism response, probably because motor fusion is more strongly developed in older children. Surgeons can simulate motor and sensory responses with PAT and design a procedure with individualized surgical dosages. A latent component is more likely to be unmasked with PAT than with the traditional Prism and alternate cover testing, thus lower rates of reoperation. Prism non-responders were operated on for the original angle. The Prism Adaptation Study, or PAS, was a prospective randomized clinical trial at 14 different sites. It was the first large-scale PAT study consisting of a specific surgical protocol requiring specific measurements and masked examiners. There were 2 levels of randomization. The first level was PAT versus no PAT. And in the second level of randomization, of the Prism responders who had motor stability and sensory fusion, half had surgery for the original angle and half had augmented surgery based on a Prism determined angle. Fresnel prisms neutralizing the distance deviation were used. Responders had motor stability at distance and near, and sensory fusion at near with the Worth 4-dot test, and they were encouraged to wear the prisms until surgery. The non-responders had either an exotropic shift at distance or near, and or built to a greater than 60 prism diopter deviation. Non-responders also had motor stability without sensory fusion after a 30-day period of wearing prisms. The test was repeated at weekly intervals up to 4 weeks. Success rates were highest in PAT responders and lowest in those who were not Prism adapted. Prism non-responders and the no PAT group had almost the same success rate. Results indicated a significant beneficial overall effect of Prism adaptation in 83% of patients with acquired esotropia. Noted in the 1-year outcome report, PAT results in a higher rate of satisfactory alignment. Non-responders tended to have an earlier onset of strabismus, and they found that visual equality was not found to be a strong predictor of success. The study confirmed, though, that allotting extra time and expense in the clinic was worthwhile. Both Mims and Wood and Geisel et al. Felt that success in the study could just be due to an increased amount of surgery after PAT compared to the less than typical amounts done in this surgery's control groups. Kushner noted in an APOSC listserv that the study was underpowered and that it was not presented clearly that the results were actually not statistically significant. Comparing a small non-randomized study by Altman to the PAS group, you'll see that far fewer patients were enrolled and that PAT was performed in a much shorter time frame. Only motor stability was used as an endpoint, so as to include younger children who were unable to give a reliable response on sensory tests, and because a positive sensory response could take up to 30 days to occur. Altman concluded that a 24-hour follow-up visit would yield the same success rates as in the dictated PAS protocol, which was a minimum of 1 week and up to a month. I've listed several PAT studies involving different diagnoses, and I will discuss them one by one. Ron and Miran also described a rapid Prism adaptation test, and this study was for exotropia, and it was completed in a single office visit. Surgical results were better in basic XT, and in 68% of cases, the surgical decision was changed because of Prism adapted angle. Both of these studies looked at PAT for the near angle in patients with distance to near disparity. This has been controversial because of a concern for overcorrection at distance, but it turned out that overcorrection was noted in only approximately 10% of the patients in both of these studies. Kuchki et al. In 1992 determined that those who had Prism adapted surgery obtained better post-op fusion without the need for a bifocal. The purpose of the Kuchki and Keach study in 2001 was to evaluate the surgical outcomes of either the built or the original angles. Those who met motor and sensory criteria had better surgical outcomes, and there was no statistically significant difference in success rates between the two groups. Kassim led a pilot study of a small cohort of patients who had PAT versus those who did not before reoperations of strabismus, which ended up to be statistically insignificant. This really was one of the few PAT studies that didn't ultimately recommend PAT for pre-op testing. And this is a study of two of the more common subtypes of acquired ET. In patients with decompensated esophoria, 82% had dose-relevant angle changes after PAT, which turned out to be a pivotal contributor to a successful outcome. And for those with microtropia that is decompensated, the pre-op PAT has diagnostic value, with half who had changes in an angle beyond what was expected for microtropia. So only a few of several PAT studies with each one of these diagnoses was discussed today because of a limitation of time. In summary, Prism Adaptation augmented surgery for acquired ET, especially those who do achieve fusion, had a significantly lower rate of undercorrection without a corresponding higher rate of overcorrection. And this justifies the time and expense involved in PAT. But speaking to the current climate of medical practice in the United States, for example, with higher than ever volume of patients, some may be otherwise motivated to do a rapid PAT. Older age at the onset of esotropia and a short duration of less than a year are in fact significant predictors of success. PAT can reliably be used in surgical planning for multiple diagnoses. However, more randomized studies with larger cohorts are needed. Thank you.
Thanks so much, Marla. I thought that was really terrific and very insightful. I have to give Marla a little bit of a shout out. She is the treasurer and member of our executive committee of the Journal for Binocular Vision and Oculomotility. This is the former American Orthoptic Journal, and I'm really excited about where our journal is going under the leadership of Kyle Arnoldi and Bert Kushner. For those of you who have an interest in subscribing, please go online to Taylor and Francis and find our journal there. But Marla's done a great job keeping our finances intact, and we're really thankful for her investment in the journal. It's my privilege now to introduce our next speaker, Dr. Aaron Miller. Dr. Miller is a long-term pediatric ophthalmologist in Houston and works with the Houston Eye Associates. He's going to be speaking on determining the surgical angle. Thanks, Aaron.
Thank you, Steve. I'm really glad to be part of this and this collaboration between ophthalmologists and orthoptists. I think it's a great way to go, and it's been a great asset to me over my career. I have no relevant interests. So when we talk about determining the surgical angle, this is sort of a combination of efforts by our team of gathering data, the orthoptists and the ophthalmologists. I think of this sort of like the analogy with Goldilocks and the porridge, where you're trying to find out something that's just right. And our goal is just to get the eye's alignment. And we have our calipers and we do our measurements for trying to determine how much to move the muscles. We've talked about how that there's measurements for motor alignment, but the sensory considerations that have been outlined really are important, that really can affect determining what your surgical goals can be. So our goal is just getting it just right, not too much, not enough, but just getting it right where we want it to be. So we've gone through a lot of discussions this morning talking about the gathering of all this data. You know, we measure the angle, measure again, we assess the sensory status and how important that is in affecting the actual potential surgical outcomes. At torsion, it's one of the gems that I always feel is often underlooked, and the importance of assessing torsion. And then we've talked about the PAT effect and how that can help guide us in trying to maximize and get the best surgical outcome we can consider. So we do all this, and then as surgeons, they take all this information, we sort of go to our surgical dose tables, and then to try to piece all this information together. So you can see we all have different ways and different places that we go to get our surgical dose information. There's tables, and there's more tables, and you can just see that there is just an enormous number of tables. The point is and I even made a table of other people's tables. So the point is that there's lots of table options to go by as a surgeon, and there's not one necessarily better than the other. There's just variations, and along those lines, each surgeon has their own different techniques on how they do things and how we recess and how we move muscles, and where we even pass the locking suture can actually have an induced resection effect. So we can get into all kinds of details that vary and why we have different results by doing, in essence, what we think may be the same exact surgical dose. Some of the surgeons measure to the 0.1 millimeters. I've worked with one of those, and I've also interacted with some people that just do small, medium, large measurements. And again, the final thing is that this, I call it the special sauce, and determining our surgical plan is this relationship and this measurement and collaboration between the orthoptist and ophthalmologist, because there truly is a sense of when you have a certain orthoptist doing a certain thing, me as an ophthalmologist, I know when I'm taking that information, it's unique to each orthoptist in my experience. So surgical angle considerations, literally there could be an entire day session on just this talk. We have infantile versus acquired considerations. There's the accommodative versus non-accommodative nystagmus. What do we do in this point, especially when trying to address null point? The restrictive strabismus, including sort of thyroid. There's the paralytic considerations and how those affect what you would sort of get. And then, of course, adult strabismus, I put in its own sort of category because it's so unique in its own right. But underlying all these things, the sensory status, it's such a critical part in assessing what you're going to do as a surgeon and how to target your surgical angle. ARC, suppression, and also fusion capacity is such a critical role in sort of guiding on how much you need to be moving muscles. But most importantly, I think that it's also listening to the family, listening to the patient, and really listening to what it is that is really bothering them, or what is the concerns. In children, obviously, we use the information we know on vision development, and that'll often guide us on what we're trying to do surgically. But when we're having our adult patients, really listening to what their complaints are, what their problems are, really will play a big part in giving you the best surgical outcome. So just briefly, I'm going to go over some important points. I think that it's really important to always consider the response to the eye alignment with maximal optical correction. And we already know the accommodative versus non-accommodative effects, where patients that respond with their full cycloplegia refraction and get good alignment, sometimes you can avoid the surgery. But then you have those that don't respond at all. And then sometimes we have this partially accommodative component where you get some improvement, but not all the way. And so typically the surgical dose is going to be considered the maximum deviation that you can measure. When you have these patients that improve part of the way, I always find before you commit to surgery and doing surgery on the residual esotropia in this example, always consider an atropine refraction, because often you will uncover additional latent hyperopia that may affect your surgical outcomes and be able to avoid surgery altogether. Of course, when we talk about patients with myopia and isometropia, those tend to be, in my experience, some more intermittent exotropia patients. Those are the kids that will come in and they have this intermittent exotropia, and lo and behold, there is nearsightedness or unilateral nearsightedness that is affecting the alignment. Again, the goal of the surgery would be to get the alignment better, but if we can improve the control with the glasses optical correction, then that can often be a good help. But typically the surgical target is based on the maximal deviation that you will have in the patient's optical correction. So age of onset can play a big role also about what we would do from a surgery standpoint. There's infantile onset. Typically the surgical target is to provide the better opportunity for that patient to develop binocularity. And typically the full surgical dose is what you're going to be shooting for and targeting. And in this case, it's usually the full surgical dose at near measurements. If you have a childhood onset patient, sensory assessment is actually much more critical to better understand how their visual system has developed up to that point. But typically the surgical target is based on this assessment. And then our adult onset, this is actually a much more complicated situation. It's a combination of all these factors we talked about. Surgical target is based on the history, the sensory, and the patient's expectations. Thyroid eye disease, I sort of classify in its own. It's one of those more common causes of adult onset strabismus. And the important point to make when making a surgical determination in these patients is to ensure that the strabismus is actually stable in size and deviations. So this is something that typically it's a sort of a lecture and a discussion on patients with these patients because they very much want this to be fixed as soon as possible. And we have just to really encourage them that our goal is to do the surgery cut, measure multiple times, but cut only once. And we want to emphasize the stability being critical. Surgical dose is much different, though, in these patients. It's much different than the surgical angle measured. These are patients with a restrictive strabismus, and therefore our typical standard surgical dose tables do not necessarily apply. Those patients that have an A-pattern esotropia without vertical strabismus on your measurements, you need to be considering that they actually may be the pattern induced by tight inferior recti muscles. So these are patients that often, despite no vertical misalignment, they may require bilateral inferior rectus recessions to collapse that A pattern and then allow better alignment with the goal of still targeting the horizontal with medials. The torsion assessment is critical in these patients. It actually will dramatically change my surgical approach on how to address these patients. Many times you will find that there's excyclotorsion, and this is a product of a tight or bilateral tight inferior rectus muscles. However, whenever I have a patient and I see that there's a vertical strabismus in thyroid eye patient without pre-op torsion, we have to have special considerations when you go into the surgery for this, because anything you do to correct that vertical misalignment will often induce torsion. So you have to plan for countering that with a secondary sort of offset of the recession, or to account for the induced torsion that you may be creating from the surgery. So special cases, which we're going to just briefly highlight on, such as nystagmus. The surgical dose is often based upon, for strabismus, use the non-dominant eye for strabismus, but then they use the dominant eye for moving the null point. When we're dealing with congenital cranial disinnervation syndromes, such as Duane syndrome, a lot of times the surgical dose and the surgical plan is based upon the surgical angle and the head positioning of that patient. The head positioning is going to be a part of what you're going to be addressing. And then we have our adult acquired from a neurological event patients. Again, the fusion capacity is such a critical part because you have to make a decision. Is it appropriate to go forward with strabismus surgery? And then their perception and their ability to fuse is also can be affected, which would affect what your surgical dosage might be. I find that adjustable sutures are helpful, not just in this case, but in the restrictive patients that I mentioned before. And so that is always a component that allows us to have less perfection, but then adjust into a much better outcome at the end. So I wanted to close with this, just sort of talking a little bit about this patient that I've had actually recently, and sort of discuss sort of the sort of how we put together my thought process and how I think about this patient. This is a 71-year-old. He had a long-standing history of strabismus per his reports, and also photo reviews dating back to childhood. He reports that when he came in, he said it's just a combination of factors. I just see sometimes some double vision. But as I found is that many adult patients, they will say they have double vision, but it's really they're worried about not qualifying for surgery, and it's not always the presence of double vision, but also the appearance. It turns out after more questioning that his appearance was also part of his concerns. He had a 15-degree left head tilt, and also there was interesting minimal excyclotorsion. So you can see on these photos, you can see how his pattern, you can see that there's this right hypertropia and the head tilt. And even if you look at the nose, there is some facial asymmetry. So just based on looking at the photos in this history, you can have a pretty good idea that this is a superior oblique palsy. We do the version assessments, which are there. And then lastly, our strabismus measurement angles. So whenever I look at this, he does have a tilt in the direction of a superior oblique palsy. The history is consistent with that. However, there's not a really left to right gaze difference in the strabismus measurements. And we'll find in some of these patients with long-standing adult strabismus will have a spread of comitants. and over time, and then therefore you may not see the classic 3-tilt head test you might see. So the question is then, well, what do we do with this patient? What can we do to help them surgically? And obviously there's eye alignment surgery, and there's different approaches. And what are we going to be charting for? What is our surgical target in this situation? Well, his sensory perception of things is going to be a big part of this. This is where the amblyoscope, the synoptophore exam, was actually can be very helpful to provide us an idea about what they would perceive if the surgery was sort of simulated in my mind. And then this patient actually was having some levels of diplopia, and it has to do with him going outside of suppression scotoma. So our surgical goal in his situation is twofold. One is the aesthetic side, getting the alignment better, but also pulling him back into a surgical suppression scotoma so that he gets rid of the double vision that's becoming more bothersome. When looking at these Strabismus measurements, our classic teaching is for every 3 prism diopters of vertical misalignment, we would do 1 millimeter recession on a vertical muscle. However, given the size of this deviation, it doesn't exactly apply. And actually, you run the risk of overcorrecting if you try to target the full 40 prism diopters in primary gaze. So in this situation, it's a combination. We could consider a superior oblique tuck. However, that in a patient with a long-standing strabismus can have a very strong effect. I tend to lean a little bit against that. I did an inferior oblique recession on the right eye, but then did a left inferior rectus recession on the left eye. And that provided him with a target angle of about 1/2 to 2/3 of the total deviation. And that actually provided him great overall aesthetic appearance, and also addressed his episodic diplopia. So I hope this was helpful. I appreciate your time, and I'll be passing this on to our next speaker. Thank you for your time.
Thank you very much, Aaron. That was great. Our final speaker, this has gone very fast. Our final speaker is Dr. Monte Del Monte, and he is Emeritus Professor in Pediatric Ophthalmology and Visual Science at the University of Michigan. He will be speaking to us on lessons learned in 40 years of preparing and handling post-op diplopia. Thank you.
Thank you, Shelley, and thank you, Steve, and thank AACO and IPOSC for having this symposium, inviting me to participate. Again, I have no conflict of interest to disclose. The next slide. We're going to talk again about my experience with preparing patients for post-op diplopia, and also handling post-op diplopia. Again, preparation of the patient is very, very important. In history, you have to ask a few additional questions just to be prepared and to prepare the patient, especially when was the onset of the strabismus and/or diplopia? Was there any head trauma or other neurologic abnormalities? How is the visual acuity, and is there an ocular preference? And has there been any previous treatment for strabismus or binocular vision? Again, especially optometric vision therapy. On examination, we've heard already today about the complete motility exam, Prism sensory testing, and binocular vision infusion potential testing. Next slide. The test I find most valuable pre-op in preparing patients for diplopia is what I call Prism sensory testing. And you place a prism over the operative eye, usually the paretic, restricted, or non-dominant eye, and I use a large 2200E as an accommodative target. Then I neutralize, using Prism an alternate cover test, the objective horizontal and vertical deviation, using the best corrected visual acuity with glasses. And then I ask the patient, do you see 1 E or 2? If they see 1, then you check the sensory and fusion status to see if they're fusing, and then recheck with plus or minus 5 or 10 prism diopters to determine if they have no binocularity. But much more commonly, especially in the young childhood acquired strabismus, they report seeing 2, even though they're at their objective angle. And then the next question you have to ask is, are they close together, or which suggests an NRC response, or are they far apart, an ARC response? And then ask if one is tilted. PAT at home with Fresnel prisms for 4 to 6 weeks can also be valuable in this setting. Next slide. And
Mon-
the way I think of the pathophysiology of ARC and diplopia in these childhood strabismus patients is patients who develop strabismus in childhood before the age of visual maturation, 5, 6, and I think sometimes even up to 10 or 12, often develop ARC with anomalous visual pathway wiring. And this wiring remains plastic throughout life, so realignment in adulthood frequently results in initial post-op diplopia. The brain now thinks that the eyes are misaligned because of the anomalous wiring. However, the rewiring, because of the plasticity, the rewiring of visual pathways generally eliminates the diplopia with fusion or a new ARC angle. And this takes usually a few days, sometimes a few weeks, occasionally a month or two. Next slide.
Hey, Monty, real quickly, our Academy web
go on.
host is asking if you could turn your camera on. We want to see your handsome face.
Thank you.
Oh, I'm sorry. I guess I thought it was.
There you go. Perfect.
Thank you.
So I think the pearl here is that persistent diplopia after surgical realignment in patients with strabismus since childhood, we're patients from surgical correction at any age. And I think this is an important point. I see patients all the time that have been told by good ophthalmologists and orthoptists and optometrists that they shouldn't have surgery because of the risk of diplopia, and that's just not the case. In 40 years of doing this, I've seen 2 patients that have had persistent diplopia. That was a problem, and both of those had optometric vision training. And next slide. However, we must warn all patients about the risk of post-op diplopia, even with severe amblyopia, with macular scarring or abnormal visual fields. And sometimes this is an expected thing after initial planned post-op alignment. For example, you want to overcorrect intermittent XTs and they're going to have diplopia immediately after surgery, or undercorrect thyroid eye disease, hypotropias for the same reason. And in those patients also, they're going to have diplopia when they go home at the beginning of post-op period. You want to demonstrate, bring out the diplopia with Prism so that they can see what it's like. And if it's present post-op, it usually resolves in a few days or weeks, and we reassure them about that. And if it persists, we have other options that we can offer, so we don't have to worry patients about the diplopia post-op. Next slide. Again, in patients with acquired strabismus with pre-op diplopia, Prism adaptation can be very helpful. It documents fusionability, defines a surgical target angle, eliminates diplopia by fusion or suppression in many patients, and it's also helpful to demonstrate diplopia to the patient to assess their tolerance to this post-op. It's especially useful if there's a distance near incompetence and you'd like to correct the larger deviation. If the deviation is variable, if there's both a horizontal and vertical deviation, and you want to see if correcting the horizontal deviation will allow the patient to correct the vertical spontaneously, or if there's abnormal torsion present, which might inhibit fusion. Next slide. Then you see the patient post-op complaining of diplopia. And again, we have to look into the history. How long has it been since the surgery? What's the vision quality like? Has the diplopia been changing recently? Are there changes in diplopia with different gaze directions? Is the diplopia monocular or binocular or both? Again, examination requires measuring visual acuity and best corrected visual acuity in each eye and going through the full motility evaluation. Next slide. Now, if it's less than 6 to 8 weeks following the surgery, primarily we're doing counseling. We counsel the patients on the healing process, the expectations that that diplopia may well resolve and the alignment may improve, and the likely outcomes. Part-time occlusion is valuable during this time to eliminate diplopia, especially while driving or doing dangerous activities. But I always tell patients not to wear the patch too much, because seeing the diplopia will help the diplopia to resolve and the patient to rewire their anomalous wiring. Fresnel prisms can be useful here as well to reduce or eliminate symptomatic diplopia, but I don't, again, like to keep them on full time because I think it prevents a resolution of diplopia. I do use Prism and wean frequently to build fusional amplitudes for deviations up to 20 prism diopters horizontally and 10 prism diopters vertically. Again, you want to use the minimal prism over the eye to eliminate diplopia and usually put in plano loaners or their prescription glasses. And then they wear those for 2 to 4 weeks and come back and you attempt to wean the prism, usually in 2 or 4 diopter amounts until you can get rid of the prism completely. Orthoptic exercises like fusion practice and induction practice are also valuable here. Next slide. Finally, after 6 to 8 weeks post-op, we have to provide some definitive treatment if the diplopia continues. Continued observation can be used in some patients if they're tolerating the diplopia well. Long-term prism glasses can also be valuable. Ground-in prisms, both horizontal and vertical, can be split if it's less than 20 diopters of deviation. Long-term Fresnel prisms tilted for the horizontal and vertical deviation can be used if the deviation is greater than 20 prism diopters. A single Fresnel prism should be tilted to correct horizontal and vertical deviation over the non-dominant or restricted eye. I still see sometimes patients coming in with a horizontal prism in one eye and a vertical prism in the other eye, which is a no-no. Those patients will not tolerate that. Again, the goal here is fusion and to move the image to the real or suppression scotoma. Next slide. And if that doesn't work, then fogging or occlusion of the non-dominant eye is usually the next step. I like Bangor to foil for this. I think it's best for cosmesis, and you can use a foil bar or trial and error with the Fresnel prisms for dosing. High plus contact lenses or glasses can also be used, and Scotch Magic tape over the lens, as popularized by Dave Guyton, can be used as well. Next slide. And finally, if medical management doesn't work, then reoperation should be considered. I usually wait at least 2 to 3 months for healing and stable deviation to set in. Test the non-surgical treatments. That also allows you to test non-surgical treatments for patient acceptance to see whether those are going to work, prisms or foils or fogging. You want to evaluate for incompetence, intermittence, and determine the best refractive and accommodative state. And this is all possible during that 2 to 3 months. And this provides an opportunity for the largest and best centered single monocular visual field with the best competence. And I would then consider offering reoperation to most patients who have deviations larger than 10 to 12 prism diopters if they're not happy with prisms or fogging. Next slide. In terms of dosing, we've heard about that from the last presentation by Dr. Miller. Standard techniques can be used for deviations greater than 10 to 12 prism diopters or torsion greater than 5 or 6 degrees. But the one thing that's really changed my practice in the last 10 years is the addition of minimally invasive strabismus surgery types of procedures, such as graded partial free tenotomy of the vertical rectus muscles by Alan Scott, central mini tenotomy and mini plication by Ken Wright. And my favorite procedure is partial tendon recession of the vertical rectus muscles that was developed by Steve Archer, and that's what we use in our Kellogg Eye Institution. And again, it's very easy. You just recess one pole of the muscle after tenotomizing about 75 or 80%, 1.5 prism diopters per millimeter recession is the dosing for 2 to 9 prism diopters of deviation. And it's really changed my practice. And these patients with small deviations that I thought would be required to wear prism glasses now can throw away their glasses about 75%, about 70 to 75% of the time. Next slide. So in summary, new or changed diplopia after strabismus surgery is a common occurrence. Understanding the causes and treatment are important to patient satisfaction. Most diplopia following strabismus in childhood onset will resolve spontaneously or is easily treated. And persistent troublesome diplopia is extremely rare and should not deter patients from surgical correction at any age. These are the patients that some of the patients that are most grateful among all my surgical patients are those that have been waiting 20, 30 years, and they come back in and they say, I wish I had known about this 20 or 30 years ago. Next slide. Thank you.
Monte, I really appreciate your talk. And with 40 years of experience behind you and under your belt, I think those are lessons that we can all take advantage of. And so really appreciate you sharing that with us. At this time, I'd like to ask all of our panelists to turn on their cameras. We do have a few moments for questions. And I actually have written down 9 questions. I don't think we're going to get to all of them, but we'll at least get through a few of them. First question, I think, is for Mary. How do you do a Hirschberg for distance?
Well, you really can't. But what we do, we note it in our chart as observation plus prism, but to have the patient fixate in the distance and really observe the fixating eye, how much sclera is showing, say it's a XT. And then you're going to move the fixating eye with a base in prism for an XT until the deviating eye looks aligned, is in position that the fixating eye was in. That's how we do it. Although I did note in the Q&A that Dr. Guyton actually cited an article that people could get to have probably even more accuracy.
Right, I noticed that. Thanks, David. Just a kind of a best practices here. I use the retinoscope for doing Krimsky because it gives you both the red reflex and the corneal light reflex, and you can balance the corneal reflex in the red reflex in both eyes using the prism. And I think that actually gives you a little bit more accuracy. And then for distance, I always try to dive down underneath the patient's line of sight and have them look at a distant target. So it is possible. How accurate it is really sort of depends on the user, I think. Anyway, next question. Does it make sense to try to use a video in an uncooperative patient to estimate Krimsky or Hirschberg measurements? I'll throw that out to the panel if anyone has a thought on that.
Yeah, I think no question that a video can be useful to get fixation. Anything that gets fixation, and if you can get your head down along the line of the visual axis, but below or above while they're watching a video, or close-up video on the patient's parents' phone, I think it's very valuable to measure Krimsky, to measure Hirschberg, and also even to get prism measurements on many patients.
Yeah, especially if you can get fixation, as you said. I think that's the key, and also your distance of fixation makes a difference in where the corneal reflexes are going to be. Right. Someone asked, is it always the sensory exam before the motor, or just an intermittent exotropia?
I have strong feelings about this.
Yeah,
I know.
Take it.
I know that I did answer that question, but I know that the rule is supposed to be sensory always comes first, but I find that inefficient. I need to do a little bit of an exam to know which tests I'm going to use, what do I need to use, and how am I going to use the test, because the same test can be used in different ways. And I think that makes my exam more efficient. So I do check vision, and I do get a primary position measurement, because that's the measurement the patient is going to be demonstrating when I do my sensory testing. And then I go into my sensory tests. I'm not one of those who thinks that, doing any kind of occlusion is going to irreparably destroy any trace evidence of binocularity. So, but I recognize that I might be in the minority in this. No, I just think it's more efficient, and visual acuity is always our priority. It doesn't matter what branch of ophthalmology we're in. So if we have a patient with a short attention span, I think we need to get the most valuable information first. And so I go with vision first.
I have a quick question for Aaron or any of the other panelists. Do you ever intentionally overcorrect with your surgical dose for ETs or XTs? I was just curious.
Well, I guess I would say in some situations, yes, you can do that. However, I guess it depends on the patient. So it's really patient specific, and a lot of it is also, if it's a really small kid and it's an infantile ET and I'm giving measurements that I think are bigger, I usually side to the bigger, intentionally overcorrecting with my surgical dose, knowing that often we're not getting the full ET. But that's how I would sort of, so it depends.
Yeah, the surgical, in my I agree with that. And I think the surgical tables for intermittent XT often build in an overcorrection. You like to see at least a 5 to 10 PD overcorrection to esotropia immediately after surgery. That's a problem in the very young children, because if it persists, you can get development of amblyopia and permanent loss of binocular vision. So you have to be on top of the really young kids. And for that reason, I don't usually like to operate on intermittent XT patients before 3 or 4 years of age. So that risk is greatly reduced, or be right on top of them with prisms after surgery till the esotropia disappears.
I would like to add something myself. In these patients, Aaron, thank you very much for your talk, by the way. In patients with partially accommodative esotropia, I like to measure the patient with and without correction. And if there is a difference, which there usually is, I like to overcorrect. I will operate for more than what I have with correction. For instance, without correction, I have 50 ET. With the correction is 30 ET. I will try and go for 40 ET. And the idea is I will shift my surgical correction curve. In this way, if the patient is straight after surgery, no problem, stay with their glasses. If they are overcorrected, I can decrease the correction, the hyperopic correction a little bit, and get them to fuse. And in this way, I can minimize my undercorrection without really hurting the overcorrections. So that's one. The other thing, in the same vein, you know, we all know that small hyperopic corrections usually don't affect the esotropia, but this is not the case post-operatively, especially in patients who don't have very good fusion. For instance, if a patient post-operatively has +1, +1.5 hyperopia, I have learned to give them this correction because their fusion is so weak that they cannot fuse any accommodative esotropia because of the +1, +1.5. So these patients have done very well with me post-operatively to give them even the smallest hyperopic correction.
I agree.
Get very satisfactory results.
May I make a comment on this as well? This is, Monte, you had mentioned about the very young. I think that the answer to this question is really age dependent. As you were saying, Aaron, you know, it's different for different patients. Adult patients, the older you are, the riskier it is, I think, to try to get that small overcorrection. I think that those patients eventually do recover, but they are miserable for a long time. A child can overcome an intentional overcorrection very quickly. The older you are, the longer it's going to take. And so for an adult, that is intentional overcorrection is not something that I think is a great idea. Unless you've done your preoperative vergence testing and you know how they'll respond.
Agree.
I think Dan is going to let us know if we're running out of time, but I heard we might be able to go over a few minutes. And since we still have 419 people on, I'm just going to ask a couple more questions here that came from the panel and one from me. So Monte, this is for you actually. What are your thoughts on the use of adjustable sutures with diplopic patients in the early postoperative period?
Yeah, I know. The biggest thing with adjustable sutures, of course, is what's your target angle. You need to know what your target angle is. And I think you're right. What you're alluding to is the risk that patients, when you're using adjustable sutures, know how you adjust them and know how you send them home. And it is a problem if you send them home with a little overcorrection in diplopia, for example, or undercorrection in diplopia, expecting that to change as they heal. And they might not like that. And we do explain in advance that our target angle is to be a little over, a little under in certain conditions, and therefore you're going to have diplopia, and it should resolve by itself. Again, there are situations where you don't want to use adjustable sutures. If you have poor vision in one eye, you have macular problems, where you don't have a good target ability to adjust. But I use adjustable sutures a fair amount in complicated strabismus, strabismus with reoperations, multiple previous surgeries, or where I don't know what to expect.
All right. We have one more question for the panel. The use of rapid Prism adaptation testing for all Prism cover testing. Do you do it? And if so, how do you do it?
As far as that goes, you know, I don't think that that's a common practice necessarily. I don't think it's a bad idea. It is time consuming, and Fresnel prisms are rather expensive. So I'm not sure, you know, unless it's several pre-op visits is a different story, if I'm understanding that correctly. But PA2 really is good because it preserves binocularity when you're testing sensory fusion. When you do a prolonged cover test or something like that, it's, you know, more difficult to evaluate the sensory status.
Yeah, I'm wondering if the one who asked the question was wondering about using the Prism bar and just pushing it slowly with time, doing
Possibly, and that's, yeah, and that's a good idea, and probably.
I'm not sure if that's really Prism adaptation or just letting the patient's fusion break down slowly over time. So
Relax into, yeah.
Yeah.
But I do find even with a rapid PAT in the office, sometimes I'll actually tape that little Fresnel trial lenses we have in all of our sets and have them sit maybe even just 10-15 minutes while they're waiting for the ophthalmologist to come in, and you can actually rapidly you know, see if they do adapt. And I do sometimes do it even on non-fusers, just for the exact reason that you were talking about, Kyle, you know, because there is some of that fusional, the peripheral fusion that we have, because I just want to know, especially with adults, if it's a long-standing strab, when will they become diplopic, where their suppression is. And it's a useful tool.
It's probably important to allot a minimum of 10 to 15 minutes wearing the prism in order to have the patient adapt to it long enough to do an accurate test on the rapid.
Yeah.
Well, I want to just say a huge thank you on behalf of myself and Shelley also for each of our panelists and for the effort that you've put into your presentations. I thought they were excellent. I really appreciate also the contributions of the members of our audience. We still have almost 400 people still with us. And we have to say thank you to Dan Mummert with the Academy, who's helped us on the front end and now the back end of this webinar. Thank you, Dan, for such a great job that you've done and for answering all of our questions and taking care of our many needs. So thank you to you and to all of our panelists and to all of our attendees this afternoon, or Shelley said this evening. There have been a number of questions about continuing education credit for this webinar. I know that there is credit available for orthoptists, MDs, and others. And so, Dan, maybe you have something to say about that. But I would say take advantage of the YouTube channel as well, and there'll be additional information there. But Dan, if you've got a comment about continuing education credits, why don't you let us know?
I don't think Dan does at this time. We did not apply for any MD CMEs, but all orthoptists in the United States will get 1.5 continuing education credit for this webinar. I too want to thank everyone, our speakers, and Dan and Sati and Sonal, everyone, for all the support that we've had putting this together. And at this time, I want to turn it over to Sati, who I think is our education chair for IPOSC. So Sati, it's all yours.
Good day. Thank you. As a member of IPOSC Educational Committee, I want to say thank you to all speakers for relevant and interesting talks, for moderators for great organizing this webinar, to Dr. Sanal and Jason Young for the huge input to all events of educational events of IPOSC, and look for more announcements for IPOSC educational events in future. Thank you all.
Thank you, everyone.
All right.
Bye-bye.
Enjoy the weekend.